Let's talk about breast disorders now. Breast disorders is not only a very important topic from the point of view of your MCQ exams, usually 1 or 2 MCQs are asked, but also from the college point of view. This is also a long or a short case in your professional exams, and you get a lot of short notes and long questions from this topic as well. So first, let's talk about the surgical anatomy of breast. Now, breast is a modified sweat gland. It is a modified sweat gland, and this modified sweat gland, the extent of the breast, the major bulk of the breast lies from the second to the sixth ribs, and from the midline, from the sternum till anterior axillary fold. But this is the major bulk. The breast can also extend superiorly up till the clavicle. Inferiorly, it can go up till the 8th rib, and laterally, it can go up till the anterior border of the latissimus dorsi. So what is the importance of knowing this? The importance of knowing this as a cancer surgeon like me is that when I have to do a mastectomy, I need to remove even the smallest portion of the breast. Even if it is extending beyond the main protuberant part, I still have to remove the entire breast so that a recurrence does not occur. You should also be aware of the axillary tail. This is known as the axillary tail of Spence. Now, the axillary tail of Spence is important because this also needs to be removed during mastectomy, and sometimes this axillary tail of Spence can become so prominent that a patient can misunderstand this for a breast lump and can come to the clinic and say that I have a lump in the breast, but in reality it is just a hypertrophied axillary tail, right? So these are some points regarding the extent of the breast. Now, the breast, majority of it lies over the pectoralis major muscle. This is the pectoralis major muscle. And over the pectoralis major muscle, you have the pectoral fascia. So this is pectoralis major muscle, and you have the pectoral fascia on top of this. And on top of this, you have the breast tissue which is there. Now in breast, there are 15 to 20 lactiferous ducts which open at the nipple. So there are 15 to 20 lactiferous ducts which open at the nipple. And in addition to that, to support the architecture of the breast or to give shape to the breast, there are ligaments of Cooper. So there are ligaments of Cooper which you can see are arising from the fascia and they are getting attached to the skin. So these ligaments of Cooper arise from the fascia and they get attached to the skin. These are the ligaments of Cooper, and they are the ones which support the breast. They are more present in the lower aspect of the breast. Now, there are certain clinical signs which are asked not only in MCQs, but also commonly in the Viva. Now, I want you to understand that if the ligament of Cooper is involved with a cancer, right? Supposing there is a cancer involving the ligaments of Cooper, what is going to happen? The ligaments of Cooper are going to be pulled inside. Now, when the ligaments of Cooper get pulled inside, the ligaments of Cooper are present in the periphery, right? So if they get pulled inside, what are they going to give rise to? They will give rise to a dimple over the surface of the skin. So you get dimpling or puckering of the skin is due to involvement of ligaments of Cooper. So this is important. Dimpling or puckering is due to involvement of ligaments of Cooper. Whereas if you have a cancer which is involving the lactiferous ducts, the central portion of the nipple is going to be pulled inside, and involvement of the lactiferous ducts is going to give rise to retraction of the nipple. So I don't want you to have any confusion regarding these signs. Retraction, and sometimes retraction is also known as tethering of the nipple. So tethering or retraction is the same thing. It is due to involvement of the lactiferous ducts. Let's just look at the images. So you can see here, dimpling is due to ligament of Cooper involvement, whereas retraction is due to lactiferous duct involvement. Now, retraction can be of two types. You can either have slit-like retraction or you can have circumferential retraction, and both of them have been asked in the MCQ exams. So slit-like retraction is seen in a benign condition known as duct ectasia, whereas circumferential retraction is more suggestive of malignancy. Now there is another very important point which I want you to remember here. I want you to remember that both dimpling and retraction are not signs of skin involvement in breast cancer. These are not signs of skin involvement in breast cancer. And I will explain to you this statement when I talk about the staging of breast cancer. I'll tell you the importance of this statement, but I want you to remember that dimpling and retraction don't make it skin involvement in breast cancer. The third sign, which is also asked quite frequently, is peau d'orange. This is orange peel appearance. Now, orange peel appearance or PDO Orange peel appearance or PDO, why does this occur? This occurs due to blockade of subdermal lymphatics. This has been asked many times. This occurs due to blockade of subdermal lymphatics. And due to the blockade of subdermal lymphatics, there can be this orange peel appearance. And if present in cancer, this is a sign of skin involvement. This is a sign of skin involvement. And in fact, there was a question which was asked in the AIMS exam a couple of years back. This is the most conspicuous sign. This is the most conspicuous sign or the most evident sign, the most well demarcated sign in a patient with a breast cancer. If you compare it with dimpling retraction and PDO is going to be the most conspicuous sign in breast cancer. I also want you to know that PDO can also be seen in benign conditions like mastitis or a breast abscess. Let's talk about the lymphatic drainage of breast. Now, the lymphatic drainage of breast, almost 85 to 90% of the lymph nodes, almost 85 to 90% of lymphatics are going to go to the axillary lymph nodes. Whereas 10% lymphatics are going to go to the internal mammary lymph nodes. So 85 to 90% goes to the axillary lymph nodes, and you can have two types of divisions in the axillary lymph nodes. One is your clinical division, which is important for your case presentation and viva. The clinical division is into anterior, central, apical, lateral and posterior groups. So this is the clinical division when you're presenting a case or in your viva. But the surgical division of axilla, when I'm doing a surgery, what is important for me is the surgical division of the axilla. The surgical division of the axilla is based on the pectoralis minor muscle. This has also been asked in the exam. The pectoralis minor surgically divides the axilla into 3 levels. And the pectoralis minor is going to divide it into 3 levels. So this is the pectoralis minor. And this is lateral and this is medial. So the lymph nodes, the axillary lymph nodes which are lateral to the pectoralis minor are level 1 lymph nodes. The ones which lie behind the pectoralis minor are level 2 lymph nodes. And the ones which lie medial to pectoralis minor are level 3 lymph nodes. So the pectoralis minor is dividing the axilla surgically into 3 groups of lymph nodes. What is very important for the exam, and this has been asked twice in the last 2 years, are the Roter's lymph nodes. The Roter's lymph nodes are interpectoral lymph nodes. The Roter's lymph nodes are interpectoral lymph nodes. That means they lie between the pectoralis major and pectoralis minor. Now, if you're asked in the exam, which level do Roter's group fall under? Level 2, right? So Roter's group are going to fall under level 2 lymph nodes, but in reality, they are interpectoral lymph nodes between the pectoralis major and minor. Another point in the surgical anatomy before we move on to triple assessment is that I want you to know about TDLU. TDLU is terminal duct lobular unit. And terminal duct lobular unit is the functional unit of the breast. And the importance is that majority of the cancers arise from the terminal duct lobular unit only. Majority of the cancers are arising from this TDLU only. So these were the points in the surgical anatomy which you should be aware of. Now we move on to a very important topic, that is triple assessment in patients with a breast lump. So triple assessment, as the name suggests, is three things. And what are the three things which we need to do? The first is history and physical examination. So mind you, history is also included in this. So we carry out a history and physical examination of the lump. And a point which I want to tell you here, when you carry out physical examination of a breast lump, we usually can follow these techniques. You can follow the dial clock method, in which you report it in the form of 3 o'clock or 4 o'clock or 5 o'clock, or you can do the vertical stripe method, or you can do the horizontal stripe method. But in the AIIMS exam last year, they asked which is the best method for doing breast examination. So the best method is the dial clock method. This was asked in the AIIMS exam last year as a video-based question. So you should know that dial clock method is the best method to carry out breast examination. Now, once we've done examination of the breast, what is the next thing which you would like to do? Would you like to do a radiological test first, or would you like to straight away put in a needle and do an FNAC or a biopsy? Well, of course, you would like to do a radiological test. Why radiological and why not biopsy straight away? If I do a biopsy straight away, what is it going to do? It's going to induce hemorrhage there, right? And because of that hemorrhage, the radiological findings will get altered. So a benign lump might appear as a malignant lump. And also another problem is that if I'm just doing a biopsy of that lump, I haven't analyzed the rest of the breast and I haven't analyzed the other breast. There might be smaller lesions which I can miss. So that is why we first carry out radiological tests, and then we move on to histopathological investigations. Then we carry out histopathological investigations in triple assessment. Now the radiological tests which are done in triple assessment, if the patient is less than 40 years of age, then we carry out an ultrasound of the breast. But if the patient is more than 40 years of age, we carry out a mammography first. Why is this division there? So this division is there because young patients have dense breast tissue. Young patients have dense breast tissue, and mammography is not sensitive in dense breast tissue. And mammography is not sensitive in dense breast tissue. What exactly do I mean by this statement? Let me just show you an example. So let's look at this example now. This is patient A. She's a young patient. And this is patient B. She's an elderly patient. So in a young patient, I want you to observe, can you observe all this whitish tissue? All this whitish tissue is dense breast tissue. All this white tissue which you can see here is dense breast tissue. And this lady has a lump as well. Okay. Now I want you to imagine if this lump, if this fibroadenoma, instead of being here, if this fibroadenoma was here, could you have differentiated between the lump and the dense breast tissue? No. The differentiation would have become very difficult because both are going to appear white, right? Which is why mammography is not sensitive in young patients. But as the lady ages, the breast becomes more fatty and black. And you can see here that you can easily make out a white lump against a black background, right? So that is why in young patients, we carry out an ultrasound. In elderly patients, we carry out a mammography. There's another radiological test, that is MRI. I'm going to tell you in detail about radiological tests once I have covered histopathological tests of triple assessment. Then we're going to discuss radiology in detail. So histopathological tests can be, you can either have an FNAC. You know that FNAC stands for fine needle aspiration cytology. FNAC is fine needle aspiration cytology. This you must have read in pathology. A question which has been asked multiple times in the exam, what is the size of the needle used when you are doing an FNAC? So you can use a 23 to a 30 gauge needle to carry out FNAC. A 23 to a 30 gauge needle can be used to carry out FNAC. Now there's another recent update which I want you to know, that is FNAC. This also would have been covered in pathology. FNAC means fine needle non-aspiration cytology. So non-aspiration cytology is done usually in superficial conditions like breast and thyroid. There is no need to do aspiration. Even a non-aspiration cytology can yield reasonable results. But I want you to remember what are the drawbacks of FNAC, right? What are the drawbacks of FNAC? So the drawbacks of FNAC, number one, it cannot differentiate between invasive and in situ cancers. Why? Because this is cytology, and in cytology, I cannot document basement membrane invasion, which you need to document for an invasive cancer, right? So I can't document basement membrane invasion here. The other drawback is that ER, PR and HER2/neu status. These are receptors which we'll be talking about. ER, PR and HER2/neu status cannot be done on an FNAC specimen. Cannot be done on an FNAC specimen. And the third drawback, I want you to watch this video and I want you to tell me what is the third drawback of FNAC. So let's watch this video and I want you to tell me what is the third drawback of FNAC. So you can see here that in this video, you can see that what is the drawback? You can see that the needle is not hitting the lump only. Every time we are missing the lump. So if you miss the lump when you're doing an FNAC, what will you get? High false negative or high false positive? Correct. You're going to get a high false negative rate. So a high false negative rate can be there if you miss the lump. And that is another drawback of FNAC. Which is why the investigation of choice for breast lumps, and this has been asked many times, the investigation of choice for breast lumps is a true cut biopsy. Now, what is a true cut biopsy? This here is a true cut biopsy gun. This is a true cut biopsy gun. This is also known as a core needle biopsy. This is also known as a core needle biopsy. And for this, we can use an 8 to 18 gauge needle. The best for breast biopsies is 16 gauge needle. Now, a common question asked in the exam is whether this is an incisional biopsy technique or an excisional biopsy technique. And students often get confused by this. So I'm just going to demonstrate a very simple thing and just keep this in your mind and you're never going to forget about biopsy techniques. So supposing you have a chocolate in your hand, right? Now, if you have a chocolate in your hand and if I just break 2 pieces of this chocolate, so I'm just taking a chunk of the chocolate, right? If I just take a chunk of the chocolate because I'm dieting, if I just take a chunk, that is an incisional biopsy. We're just taking a piece of the chocolate. But if I eat the entire chocolate when I'm not dieting, then that would be an excisional biopsy of the chocolate. So if you remove the entire tumor, that is excisional biopsy. But if I just take a chunk of the tumor, that is an incisional biopsy. And here I'm just taking a chunk. So this is an incisional biopsy technique. So investigation of choice is true cut biopsy, but the gold standard investigation is an excisional biopsy. The gold standard investigation is an excisional biopsy. Now, what is the difference between a gold standard and investigation of choice? I've covered this at other places as well, but I'll just give you an example and it will be very clear to you. Look, a gold standard investigation is one which is going to give you the diagnosis 100% times. But it might not be the most feasible investigation to do. Let me just share a clinical example with you. So, a few months back, I got a 45-year-old lady who had come from a village and she had a hard breast lump on the left side, right? And she came to me and she said, well, somebody sent me to you and I want to get this breast lump removed. Now, when I examined this, I found the lump to be suspicious for cancer. So I said, first I'll do a biopsy and then we'll do the surgery. But there is a common myth in our country that if you do a biopsy of a lesion, the cancer starts to grow more aggressively, right? So this lady said the same thing. She said, no biopsy because my elders have said this is going to spread. So you just remove the entire thing. I said, ma'am, I'm not going to do that. So she went away. She got the surgery done elsewhere and then she came back to me with the report. And as suspected, it turned out to be a cancer. And then now she came and told me, now what do I do? And I told her, well, you'll require another surgery. Why? Because we haven't addressed the lymph nodes and I have no clue whether the entire tumor has been removed or not, right? So that is why excisional biopsy will give you the diagnosis, but is it the most feasible investigation to do? No. In this lady, if I would have done a true cut biopsy, I would have known that it's a cancer straight away and I would have dealt with the cancer in one surgery instead of two surgeries. Okay. So that is the difference between gold standard and investigation of choice.